Well, good afternoon, everyone, and a massive welcome to this next instalment of the UKHSA and Turing lecture series. So my name is Fergus Cumming. I'm the UKHSA representative here today. So I am Deputy Director for Advanced Analytics and Chief Economist at UKHSA. As many of you will know, the UKHSA is responsible for protecting every member of the community from infectious diseases to lots of other health threats. And one of the things that has kept us busy in the last few months and years is response to the pandemic. And I had the privilege of working with Meng along those days and months, and indeed colleagues from devolved administrations. So I'm really excited about the lecture we're going to have today. But before that, I want to hand over to Alicia from Turing.
Many thanks, Fergus. Myself, I'm Alicia Davis. I'm the health theme lead in the AI for Science and Government programme within the Alan Turing, and also actually the head of research and evaluation based in Public Health Wales as well, back in Cardiff. I'm very pleased to be here today. Now, for those of you maybe that don't know much about the Turing RSS lab itself, it's a partnership between the Alan Turing Institute, the Royal Statistical Society, and the UK HSA, the Health Security Agency. It was established in 2020 during the pandemic to bring together research methods for statistics, mathematical modelling, and data science into the health surveillance systems to help support in the COVID-19 pandemic response. So with that, under that programme, there's this international lecture series bringing together leaders who have helped to respond to the COVID pandemic and the lessons learned and reflections as well too. So without much further ado, I'd really like to welcome Meng. It's wonderful to see Meng here from Public Health Wales. Now, Dr. Fu-Meng Khaw is the National Director of Health Protection and Screening and the Executive Medical Director within Public Health Wales. And Meng, over to you to reflect on the experiences in the Welsh management of the COVID-19 pandemic. And we hear from Meng for about 40 minutes or so. And please do, if you want to ask any questions, there's the Q&A button at the bottom, so feed them through that way, and we'll have time for questions and a bit of discussion towards the end too. So Meng, over to you.
Great. Oh, thank you, Alicia, and thank you, Fergus, for the very warm welcome. And, you know, it's a delight to be here, to be contributing to this series of international lectures. And, you know, I have the privilege of having worked in the English system as well as the Welsh system throughout the pandemic, probably in equal halves, actually, because I've been in Public Health Wales now for just over a year. So this lecture is about providing a perspective from Public Health Wales, which is the National Institute for Wales for Public Health, and we provide advice on public health matters. And health protection is one of our statutory functions that we have since the organisation was established in 2009. So I'd like to take us through some of the context in case, you know, our audience members don't really understand devolved administrations in the context of health. So Wales is a devolved nation of the United Kingdom. It has a population of 3.1 million, and it was established with the Welsh Government established in 1999. And health is one of the devolved areas of business, for which there was a budget in Wales of about 9.6 billion in the last financial year. Now, NHS Wales, of which Public Health Wales is part, has 7 health board areas, and these health boards actually deliver and commission, if you like, the services provided in hospitals and also in primary care. We also have other trusts within the NHS, but we work very much together as part of the public endeavour. And of course, we remind ourselves that Aneurin Bevan, the founder of the National Health Service, was Welsh. So you'll be familiar with the early days of the pandemic, the degree of uncertainty, the degree of anticipation for the first case. And for us, the first case in Wales was announced on the 28th of February by our Chief Medical Officer, Sir Frank Atherton, who you'll see in the picture on the right there. And one of the things we continued to do was to provide information to all our stakeholders, including members of the public, through our dashboard about the numbers of cases and the trends. And I'd like to take the opportunity just to show you some of the data that we presented. And part of that was to inform the establishment of the Test, Trace and Protect system, which was our local Welsh system, which was delivered at a local level. Our contact tracing endeavours were very much owned by our health boards and local authorities, and Public Health Wales worked very closely with them. We also had an ambitious task of implementing testing and genomic sequencing, and we helped use the information to establish and implement some of the restrictions that were manifest as the alert level announcements for non-pharmaceutical interventions, which were really, really key, particularly before we had vaccination for COVID, which took a while to be available. And of course, when it was available, the implementation of the vaccination program became the mainstay of the control measures to control transmission of COVID. The introduction of the COVID pass was a part of those control measures. But in terms of the information then, that we put in place, I mean, at the early stages, we moved very quickly into daily reporting of cases, and we carved the data up into many, many different ways. And this required a really innovative new approach for our teams to present the data and continue to refine that according to the needs of our stakeholders, which included Welsh Government, health boards, local authorities. I don't propose to go into the detail of this slide, but suffice to say that this was a dashboard presented at local authority level, showing very quickly the trends in the data in terms of the incidence rates and changes from the previous week and the test positivity rates. We continue to do that throughout the pandemic, and currently we're on a weekly rhythm, having moved from a 5-day-a-week reporting just recently. We also looked at the confirmed cases and how we share that data around the age profile, and you will see the trends are tracked over time as to which age groups are most affected in that period, and we tracked that over the course of the pandemic. We also looked at a really important indicator, which was hospital admissions. You know, this was one of the most important things we looked at for in terms of the severity of disease and impact of the pandemic on the health system. So we monitored this very carefully. Now, this is from recent weeks, and worth noting the continued decrease in the trends for hospital admissions, and likewise for admissions to critical care. Because one of the things that we wanted to be sure about was that we weren't exceeding our critical care capacity as well. So there was a dynamic interplay between the risk assessment arising from these sources of information with interventions that we put in place to ensure that our systems weren't inundated, and more to the point that our population outcomes were at safe and acceptable levels. When you look at the trends over time by age group and the hospital sampled COVID cases, you can see instantly the peaks and troughs of the pandemic throughout the 2-year period or so. And you can see that the age groups that dominated throughout, and these are expressed as rates per 100,000 population, that the over 65s in the brown and the over 85s in the purple dominate throughout the pandemic. So that was a common theme, and clearly those were the most susceptible and most vulnerable of our populations, and therefore any policy and strategy around protecting those most vulnerable was influenced by having access to this information. And you know, looking at this in terms of the wider population, we are able to also explore the trends by sample collection date and how they pan out in the different waves, and understanding the actual impact of COVID. And this is the confirmed cases, that the numbers of cases were much higher in the Omicron wave, which is this the last spike here, compared with the other waves. But clearly, this is all interpreted in terms of availability of testing behavior. So always we look at the context and to interpret the information on a real-time basis. When we look at the distribution by health board areas, just to remind you, there are 7 health boards in Wales across the 3.1 million population. There was actually very little difference in the end between health board areas. But perhaps in the a second wave, the so-called alpha variant, we did see some variation between our health board areas. But I suspect if you put confidence intervals in, some of the smaller health boards like Powys right at the bottom here, which is the smallest health board in Wales, there might have been confidence intervals that suggest it might have been by chance and by sampling of the cases. And looking at hospital admissions by health board as well, there were some variations. Again, you can see some of the smaller health boards with lower incidence rates for hospital admissions. So I think this was useful to look at as a trend overall for comparison between places, to understand whether there was a need to take local interventions versus national interventions. And I'll come on to that later. Now, clearly, there is an issue around interpreting hospital admissions, because some of those cases would have been acquired in hospital. Some of those cases, most of those cases, would have been acquired in the community. And therefore, case definitions are really important whenever you describe an indicator. So whenever we present data such as this, we are very careful at providing the case definitions. So what do we mean by community onset case of COVID? And this is where, you know, a sample was taken in a community setting in Wales, or within the first 2 days of hospital admission in Wales, accounting for the incubation period of a case. And the hospitalized case would be someone where someone is hospitalized within 28 days of a positive test. And this allows us to then explore the interchange between community onset cases and hospitalized cases. And when you look at the trends here, actually the proportion of hospitalized community cases diminished significantly. And we know that for a fact for the Omicron wave. And that's why the interventions that we put in place were proportionate to the clinical impact that we had from those cases. And clearly, mortality, death is another outcome that we monitor very carefully. And you will note very quickly that the mortality counts, and that's the numbers, did decrease significantly after vaccination was rolled out. Towards the back end of 2020 and early 2021. And Wales was very quick to vaccinate its population and achieved its targets ahead of time. Now, clearly, I talked about testing strategies and availability of tests, and we saw some significant changes of that in the beginning of this year. So the use of LFD testing influenced our ability to monitor the PCR detected tests, and also the cessation, the stopping of universal testing in the community on the 1st of April also meant that we had to interpret our findings a little bit more cautiously. So on the left here are the PCR tests that Public Health Wales was monitoring and constantly monitored PCR positive tests in this way. But this is triangulated and corroborated by other sources of information, such as the prevalence estimates by the ONS, the Office of the National Statistics Infection Survey. But what's clear here is that the trends are mirrored, but the absolute prevalence estimates would have been different because there wasn't the universal testing offer from the 1st of April. And that's why I think going forward, triangulation of multiple sources of information gives us the ability to understand the progression of the pandemic a little bit better. We also established a service for genomic sequencing in Wales for SARS-CoV-2, and by October 2021, we achieved 100,000 genomes. And actually at the time, it was regarded as a world-leading service, being 9th in the world for the number of sequences shared through the international platform, and the 2nd highest for the percentage sequenced and shared at 21%. And genomic sequencing allows us to characterize variants, identify trends in the variants, and allows us to track the progress of each variant as they arise. So it's been an important part of our toolkit for pandemic response. And we continue to monitor our variants in Wales, and as you can see, the dominant variant now is Omicron, as shown in the purple bars there. But as the numbers have fallen significantly because of testing, some of the detail will be lost in that granularity. But Omicron is certainly the dominant variant in Wales. The coverage of sequencing will change with time. So when there's a peak in activity, then our ability to keep up with the numbers drops. So our percentage of sequencing falls. But you can see that throughout the course of the pandemic, we were at times achieving about 75% of all PCR positive cases. And, you know, on the average, I think it's about 30 to 50%. And clearly at times when the activity is high, it will drop. But I would suggest that 10% was a very good sequencing rate at those peak activity times. We continue to try to understand what is the best rate of surveillance for whole genome sequencing for the future. So other evidence and information that we share was gleaned by understanding how the public were feeling, how they were experiencing health and well-being, and how they were behaving in terms of the control measures. So we commissioned the WHO Collaborating Centre on Investment for Health and Wellbeing, which is part of Public Health Wales, to undertake population level surveys. And we continue to do this throughout the pandemic. And I'm just going to show you some of the outputs of that population survey. It asks about physical health, about whether people are feeling unhealthy, and it plots it by trends as well. And it looks at mental health and concerns around mental health and well-being. And the reason why we should take these seriously is that I think we understand that behavior science is really important in terms of trying to predict population level behavior in response to the interventions, not just about COVID control, but also about impact on wider health and well-being measures. So we have a prevention and behavioral science cell that one of our members of staff leads, and that plugs into the technical advisory group that is part of the Welsh Government response to the pandemic. And throughout the course of the pandemic, the cell would provide evidence around behavioral insights to inform policy and strategy changes. And you know, some of the detail around this is to understand, well, what are the key messages we want to communicate when we're communicating risk? What behaviors do we want the population to take? So, you know, can we leverage positive social norms? The pandemic has created lots of armchair epidemiologists. Everyone's an expert. And I think the levels of health literacy are really, really high. And I think that offers us an opportunity to really build on that and ask ourselves, well, what can we do, including COVID transmission? What can we do to use that health literacy level to modify people's risk-taking behavior around diet, around physical activity? So I think, you know, the lots of developments on the way. to see how we can maximize those opportunities. So I'd like to talk a little bit about control measures. Now, control measures clearly was different before we had vaccination and after we had vaccination, because with a protected population, the restrictions you put in place need to be proportionate to the immunity levels that that population has. As I mentioned earlier, Wales had a really good start at the vaccination campaign. The health boards essentially rolled out the vaccination campaigns en masse and achieved quite a high uptake rate, certainly for the first dose, the second dose, and the booster. As of the 1st of June, these are the rates across those older than 12 years. And the total number of booster doses given is 1.98 million. When you compare that with our population, that's, you know, a good percentage, 72% have been boosted. So right at the outset, and people will remember the move to the national restrictions in March 2020 to delay the promulgation of the pandemic. And we relied very much on the modeling that was done, the modeling of interventions built on, you know, some of the assumptions, and Imperial College actually produced something that helped us understand how each of the interventions would play out in terms of critical care beds. Because at that time, there were huge pressures on the NHS and huge pressures, particularly on critical care beds. When you look at the detail, so it's exploding this bit of the graph above, the red line here is the critical care bed capacity. And then the modeling of the interventions will demonstrate that actually, no matter what you did, most of the time you were at risk of exceeding the critical care bed capacity. So monitoring that was a really important part of our evidence gathering. But if you look at the detail here, so doing nothing at that point in time in March would result in this peak very early on. However, looking at school and university closures, case isolation, and general social distancing would merely delay the peak to the green line here, but the peak was of similar proportion if you did nothing. However, if you did further restrictions through case isolation, household quarantine, and general social distancing, then you would flatten and delay the peak. And that's what happened. So, you know, I think modeling played a really critical role in determining some of the policy decisions that were taken at a UK level, but also at the Welsh Government level, who had access to independent modelling for the Welsh population as well. Now, there was a notion that you needed to do repeated lockdowns to achieve the control and the dampening of the effect. But, you know, this was the modelling about how the restrictions in these blue square rectangles would play on the number of cases in orange here. But actually, and then these were ICU cases, but actually it didn't happen in that way. So the restrictions weren't implemented in that way accordingly, because this was a dynamic risk assessment. So what actually happened was that we saw three main waves, really. So the wild strain, the alpha variant, and then the Delta variant augmented by the Omicron variant. So I think peak 3, the wave 3 was really an amalgamation of Delta and exacerbated by Omicron. And when you look at the interventions that took place, these are the grey bars. These are meant to be points in time when those interventions were put in place. I won't go into the detail of this. People will be familiar with the restrictions that were put in place in the UK, but probably less familiar with the restrictions in Wales. But we continue to track this, and it's published on the Welsh Government website. So wave 1. What happened? What did we do? Now, clearly, you know, the numbers of cases in blue here demonstrates that we had a peak in April, May time, and this was the national UK-wide restrictions in the green that were put in place. The red interventions are the local interventions that we put in place across pockets of exceedance in Wales. And what that demonstrates is, that the peak still, looked like what we would expect for a peak in spite of those restrictions that were put in place. And this comes back to compliance, enforcement, and behavior, which is why the behavioral insights are a really key part of predicting the outcome of any restrictions that we put in place. Now, in wave 2, which was the alpha variant, the variant that was first identified in Kent in around about September 2020, there was a recommendation from the Scientific Advisory Group for Emergencies, SAGE, to establish a circuit breaker. And this was a widespread lockdown to then control transmission and delay the peak. And a whole list of non-pharmaceutical interventions were considered as part of that. And don't forget, that was a time when vaccination was, just about being completed for rollout. But certainly the population wasn't protected by acquired immunity. But many, of course, will have been infected by then. Now, Wales actually introduced this for a 2-week period. But there were complexities about introducing it because it wasn't taken up by UK government. And the funding arrangements meant that it had to be considered in the context of what Wales could fund to maintain that lockdown. Now, it is possible that had it been for a longer period than 2 weeks, that we might have seen a different outcome. So here we are with the 2-week fire break in the green here. And what we could see is that there was a small impact on number of cases. So the peak started coming down, but then as soon as the restrictions were lifted, there was then an increase in cases during the winter of 2020-2021. Now, some of these smaller red and amber bars are the local interventions that we put in place because there were exceedances in Caerphilly, in Merthyr Tydfil, Rhondda Cynon, where we put in the local restrictions. But it was recognized that actually those local restrictions didn't have the impact that we had hoped for across the whole of Wales, which then led to the thinking, I'll skip that, which led to the thinking through the publication of the Coronavirus Control Plan in 2021, that actually having clear, simple and fair interventions across the whole of Wales by having nationwide restrictions was better understood and therefore complied by the population in Wales. So moving from a traffic light system, the Welsh Government established an alert level where alert level 1 was low risk, alert level 4 was very high risk. More recently, the introduction of alert level 0, which was the baseline alert level, was introduced late in 2021. There was also a 21-day review cycle, which took into account the epidemiology, the emerging evidence that then determined what alert level Welsh Government would put in place in Wales. And Public Health Wales played its role in that, in providing advice, and also the Technical Advisory Group, which was set up as a cell in Welsh Government, also provided advice, and Public Health Wales played its part in that group as well. So the move towards a national approach to restriction, you can see quite clearly set out here, where the national interventions that were put in place and the national relaxation, which is in green, you can see that the local restrictions that were put in place came to an end with the publication of the alert level system, where all the interventions thereafter were done on a national basis. I think as we were starting to come out of Omicron, there was a move towards local risk-assessed interventions in schools and in hospital settings as well. So it was more about recognizing that there will be local variation. And I think that's always the challenge between local and national, no matter how big the population. So did it work? And, you know, if you look at mortality as the most important outcome measure, we appear to be higher than many of our counterparts in Europe, but certainly below average when compared with the European Union and below average when compared across the UK, but we're certainly higher than France and Sweden. But when you look at the United States, that's certainly much, much higher compared with Wales. And I suppose one way of looking at it is, what is the susceptibility of the population? Because case mix is a phrase we use to understand what is the vulnerability in your population that renders it more susceptible to the impact of COVID. I think we acknowledge that in Wales, we've got health inequalities that have been pretty intractable over the years, and that when you look at the stark statistics of the impact of COVID, those living in the most deprived areas have an adjusted age standardized mortality rate that's almost double those in the most affluent areas. That is a stark statistic. It is what it is, but I think it really calls for action to address that for this pandemic, for future pandemics, that our systems and processes need to recognize the inherent inequities in society that generate these poorer outcomes for people in more deprived communities. So the continued role of evidence, you know, let's move away from the epidemiology, is looking at the building the evidence base, you know, whether it's primary research, secondary research, collating and compiling the evidence. We had mechanisms in Wales to be able to do that. Funding was provided to establish a COVID-19 evidence center, hosted, I think, in Cardiff, but working across other universities like Bangor, included Public Health Wales, Health Technology Wales, the Wales Centre for Evidence-Based Care, and the SAIL Data Bank hosted in Swansea University. So it's really a combined effort to make sense of the fast emerging evidence base around. And I think the centre is able to look at 50 evidence questions per year, and so far has produced 28 rapid evidence reviews, and that began in March 2021. And clearly the coverage was wider than just COVID, and there were wider impacts that were considered as well. And some of the examples are the review of face coverings and how it influenced the move to alert level 0 in August last year, and the evidence on infection control measures in schools to inform the reopening of schools in September last year. And you can look at the outputs of the Evidence Centre through this link on the slide. And I've just put in a snippet from one of the reviews that was presented to the Welsh Senedd in November 2021. Public Health Wales played its role and issued advice notes to the Chief Medical Officer, and that began, actually that should say October 2020. So at the beginning of the pandemic, we actually started issuing formal advice notes to inform policy and strategy decisions. And to date, we've issued 29 advice notes. And I think what was different from our advice notes compared with the Centre for Evidence for COVID was that we took into account operational elements, so feasibility, deliverability. And I think those elements are really, really important. And so is the theoretical evidence basis for our response. So we, for example, gave advice around the reduction of the isolation period, clearly looking at the evidence that had come up from the work that UKHSA had done, but we put in place our own risk assessment of taking that decision in Wales, which is why I think as a national institute, we have a really clear role in offering independent advice to government for decision making. We're quite early in our thinking about how we move towards an endemic state response. And in January, commissioned by the health minister, we put together a transition plan to clarify our thinking about endemic response. And that's what I'm going to spend the rest of the time talking about. So our approach to endemic response is, first of all, to understand what endemic is. And, you know, our working definition is that the endemic is where you have safe, low, acceptable levels of COVID transmission that are predictable by season as well as by, you know, locality. And we felt that in order to get into the detail around endemic response, we need to consider the testing, diagnostics arrangements, the treatment arrangements, our surveillance and continued gathering of evidence, and then how we prevent and control, but recognize they are interdependent. But there are also some overarching issues that we have to address, like inequalities, how we plan and develop the workforce, how we apply behavioral science, and how we communicate with the public. And we need to look to the past to define the future, i.e. the lessons we've identified and learned from our response so far. And there is clearly a need to be proportionate in our response when it comes to testing. We simply can't sustain the rollout of the testing arrangements that we put in place throughout most of the pandemic by offering universal testing in the community for asymptomatic cases, predominantly using the LFD test, but also on certain occasions using the PCR test as well. Now, that was all stood down pretty much on the 1st of April. Certainly the PCR testing in Wales, we've retained LFD testing and continue to offer it until the end of June. And there's a current discussion about continuing it beyond the end of June. And that's a Welsh Government decision. We have to recognize that testing is now commonplace in clinical practice and in society. And there's a certain level of expectation about testing functions throughout our systems. But we do need to ensure that we have a proportionate to the risk and sustainable strategy for testing. And how we define that is to understand why we're testing. So the purposes of testing, I think, need to focus on testing to diagnose, to offer the right clinical treatment, and testing to safeguard, i.e. how do we control exposure of vulnerable individuals to viruses, and testing to maintain, enable, and testing for surveillance. We also need to understand what the choice of the test is. There's a whole range of tests now. We know and are familiar with the point of care testing, for example, LFD tests. PCR testing is familiar to us. Variant assays have had their place in early detection of variants, and also whole genome sequencing, which is the gold standard test for ascertaining the genomic sequence of that particular variant. And I think, you know, variant analysis and genomic surveillance will continue to focus on, you know, how we detect variants as they emerge in communities, how we manage incidents by understanding what's the dominant variant in that cluster, and how it can influence treatment decisions. Because one of the things that came out of Omicron is that Omicron variant was responsive to one of the treatments, but not as responsive to the other. So early detection of the variant is important and has a direct impact on outcomes. And we know that there will be future treatment options, and we know that the triggers for those options will vary according to the context, but really exciting time for the development of new antivirals and monoclonal antibodies. So what about surveillance and evidence? How do we take this forward? We need to understand what are we aiming to do. So surveillance needs to be purposeful, targeted, and systematic. It needs to be able to link across multiple data sets, especially at this time when we don't have universal testing, and we need to be able to enhance it in response to certain emergency situations. However, I'm really clear that COVID surveillance needs to be integrated with the thinking of other respiratory illnesses, particularly during the winter months. And on the right at the top, there is a bar chart and trends of the cases of a range of respiratory illnesses that we've been able to monitor using our multiplex assay to look at the numbers of cases for each of these diseases of concern. And you can see immediately that you can track the trends of each of these. And when you explode into one specific infection like respiratory syncytial virus, which affects some individuals, particularly children, there was an unusual spike earlier in the year last year, which we couldn't really account for, which gave us the ability to start preparing campaigns to ask people to look out for the warning signs and the signals. However, that didn't manifest and that didn't propagate. So we've been continuing to track it and notice that there's a slight rise in numbers of RSV cases in recent weeks, which we will continue to monitor. But that's the beauty of plotting trends, and these are the previous year's data to allow us to understand, well, what did we predict would happen, and therefore what was in exceedance of the levels that are predicted. And that's the approach that we will take with COVID as well. So over time, probably 3 to 5 years, we'll have a better understanding of the behavior of COVID in a vaccinated and largely immune population, and what its impact is, and whether there are any seasonal trends. And if there's any exceedance, by doing plots like this and possibly statistical calculations, we'll be able to predict whether it's in excess of what we expect. Some of the outcomes of surveillance allows us to detect early and act early. And some of it's about controlling the outbreaks that might be emerging in high-risk settings like care homes. But also genomic surveillance allows us to inform vaccine development and influence the policy around that as well. And the last area within our transition plan is, what do we continue to do around prevention and control measures? It needs to be proportionate to the risk. So, national lockdowns may be a thing of the past, but actually they may have their place if you've got a new variant that has escaped the vaccine, where none of the population is therefore protected. And clearly no one wants that to happen, but we need to be vigilant. And that's why we need a strong surveillance system to be able to detect that and monitor that. The focus we have on prevention and control has to be continued to be on vaccination. That is our one single tool to control future cases of COVID by protecting at a population level. We need to understand what we do around the health protection response. We've stood up a huge infrastructure to respond to the COVID pandemic, starting from a zero baseline, really, when we think about all the contact tracers that are now in the system and that have contributed to contacting cases and contacts where relevant, and the amount of logistics that have been put in place to put that infrastructure in place has been phenomenal, and is one of the successes, I would argue, of the COVID response across the world. I think we really need to focus on behavioral insights as well. Do we have a good understanding, and how do we continue to have a good understanding of how a population behave at a community level and at an individual level? And therefore, how do we communicate risk to people to take the behaviors that we want them to take when we need them to take it? So when we get a spike, it may be at a community level, what messages are we giving to give people the view about the level of risk, and therefore the interventions and actions we want them to take? Clearly, infection prevention and control will continue to play its role, particularly in high-risk settings like hospitals and care homes, where we really don't want any so-called nosocomial transmission in those settings. The enablers for prevention and control, there needs to be whole system collaboration. What we see in Wales is that it's really brought us all together as a whole system, working across local authorities, across health boards, and with Public Health Wales. And clearly the command and control emergency response structures have also been stood up with the local resilience forums involving police, fire and rescue, and the blue light services. We need to understand the workforce requirements, so we need to plan ahead. If there was a surge and we've lost all our contact tracers, how are we going to establish that whole infrastructure again? But we've got people who are experienced and skilled already. How can we draw upon them if they're no longer in our workforce? We need to establish the best digital infrastructure for data sharing in real time to allow us to respond. And of course, a lot of this costs money, so we need to understand what would be proportionate investment to meet with the future demands that we have. And clearly welfare concerns, particularly at this time with the cost of living rises, that we need to take into account in a different context. And I think we also need to take a broader perspective. How do we monitor and address the wider impacts? The wider impacts that are not the direct harm to individuals from the infection and the complications, but the harm caused by NHS services being overwhelmed, so waiting lists have increased, the harms from non-COVID illness because people are not seeking medical attention or delayed seeking medical attention, and there's a lot of evidence about those broader harms, higher rates of disease, uncontrolled diabetes, etc. And there's obviously the socioeconomic and societal harms, such as the economic impacts of closures of businesses, job losses, etc., that we absolutely need to take into account. So one of our ambitions in Public Health Wales is to continue our thinking around how we address health inequity. So the Welsh Health Equity Status Report Initiative, which is led by the WHO Collaborating Centre hosted in Public Health Wales, has come up with this report, and the links there on the slide for you to look at in more detail. But it considers, health and income security, living conditions, social and human capital, and employment and working conditions. It's a really interesting read and really powerful, and probably a foundation for the action we need to take to address health inequities. So I'm coming to the end of my talk now. So what of the future? What are the future priorities? And I've just shared in 4 bullet points something that I've been thinking of, but everyone will have different views to add to this slide. But I didn't want to make it too busy because I want it to be manageable. Because I think what we've learned in the pandemic is that we can't boil the ocean, but we need to understand the steps we need to get to be able to even touch some of our goals that we want to achieve. So I think we can continue to identify the lessons to inform our future response. So I'm already understanding that the COVID response has enabled us to develop relationships across a whole range of organizations that has helped us to respond to the Ukraine crisis. I was on a mission to Poland recently, and having seen some of the structures that they put in place to respond to the humanitarian needs of Ukraine refugees, 3.2 million of which have gone across the border to Poland, has really been helped by the relationships and the structures that were established for COVID response. So how can we build on those to actually build a stronger response mechanism in the future? We also probably need to sit back and evaluate some of the key interventions we put in place. Contact tracing was a phenomenal effort, but the question I would ask is, did it change the outcomes? Did it change the numbers of cases? Did it control transmission? There may be evidence out there already, but I do think we need to be clear on that before we jump in and do the same again, because we might just get exactly the same that we got before. Wastewater surveillance was really the innovation for COVID pandemic, and it really helped with our understanding at a community level about levels of COVID. But I think the jury is out as to its future role, because I think it's wider than COVID. And let's not forget, wastewater surveillance started off around the question on antimicrobial resistance, but it's been transferred to understand the epidemiology of COVID. The third point, I think, is a really important one, which is, what does the system require for an effective response in the future? What does it need for a standard response, and what does it need for surge? Do we have enough capacity in the system to deal with the surge that might come our way? And then the last thing, never to forget the broader harms, because I think for those of us working in communicable disease control, whenever there's an infection, we jump, don't we? And sometimes we jump higher than possibly we should. So whatever we do around this needs to be proportionate, and we need to also develop an understanding of what the broader harms are that are building up because we're jumping so high for communicable disease response. So thank you everyone for listening, and I hope that's given you an overview, a very, very quick tour of my experience working in Public Health Wales in responding to the pandemic so far. Thank you.
Meng, thank you so much. That's just been absolutely fascinating, and I think we could spend days on this. So I think you've done a fantastic job actually in cramming it all into about half an hour and 40 minutes. We will finish at 3, but that means we've got a little bit of time just for a couple of quick questions from the Q&A. I can see actually there's one there that's in relation to genomics and whether the genomic variants and that information can help to provide insights on vaccine effectiveness, hospitalization, death for different variant types, and a supplementary one there about where's the best place to acquire or link in with the genomics team in Wales. Would you like to take that one, Meng?
Yeah, so genomics plays its role in understanding vaccine effectiveness, because if we weren't able to characterize Omicron, for example, we wouldn't really know that the vaccine effectiveness was, behaving against Omicron. We would guess that it was because we might have an understanding that Omicron is the dominant variant. So I think it does play a role in really consolidating our understanding. However, I don't think it's just genomics that we need in terms of characterizing vaccine effectiveness, and there are formal vaccine effectiveness studies that take place, and UKHSA are leading many of those because they have access to the information and the data sets to allow us to do that. And I think working across 4 nations, 5 nations, including Ireland, gives us the opportunity to add power to those vaccine effectiveness studies, which need to be rigorous because the impact of getting the right outputs is quite significant. And then in terms of the best place to acquire genomic data and its metadata for Wales, I'm happy for you to drop me a line, Fatima, after this, and we can explore that further. I think it really depends on what level of detail you want and for what purpose. So happy to follow that up with you directly.
Thanks, Meng. And then there's another question there on the temporal changes, really. So temporal changes to physical, mental health, and how to understand that. We're in a situation of pandemic where everything's changing over time. And I wonder if I could add into that the behavioural insights as well. So people's behaviours are influenced by so many things that change over time. So what's your view on how we can integrate more of that temporal health, non-infectious disease health bit in?
Yeah, I think we have a good baseline understanding about seasonal affective disorders, that season does have an impact on people's health and well-being, whether it's mental well-being or whether it's physical. And I think if you add infectious disease on top of that, then I can imagine it can only exacerbate those outcomes that we're monitoring. I think what's important here is not so much making, judgments about the evidence on this or speculating the impact, but what's important here is monitoring and having the surveillance mechanisms to continue to build our understanding about the population, whether it's surveys, whether it's surveillance of disease rates. I think that gives us the ability to fine-tune the interventions that we can put in place at a population level. And we mustn't forget the power of taking interventions across the population.
Thanks, Meng. And Fergus, I know you had a question.
Well, first of all, thank you very much for a fascinating tour de force, Meng, and thanks on behalf of UKHSA as well. So I'm interested, you saw the pandemic from so many perspectives and so many sides, including England and Wales. Out of everything, what surprised you the most over the last 2 years?
Oh, wow. I wasn't expecting that question. I think what surprised me the most was the ability of human society to coordinate on this scale, to respond to a massive threat to us. And the advancement of technology to allow us to do that most efficiently. One specific example is remote working. I remember the early days of the pandemic relying on, should I use the software system, relying on Skype technology for interactions. And soon it became clear that it was not easy to do business. And I think, other platforms then enabled us to do video conferencing more effectively. And I'm amazed at how effective it has been for us to interact across the waves, as it were, which meant that we were able to do business to respond to the pandemic. Because if we had to travel, and okay, I was traveling, I was a key worker and I was allowed to travel to be part of that kind of core of the response in Public Health England when I was there. And certainly in Public Health Wales, we did some of that. But the ability to connect effectively across the waves has been a major breakthrough in the way that we work, that I think is disruptive technology. If you look at how we might work going forward from now, actually most of us will probably do a mixture of both.
It's been really fantastic to hear from you and to hear from the experiences in Wales, but also importantly, that kind of look to the future about what we can learn from the COVID-19 response and the good work that was done into robust, reliable and really responsive health surveillance systems. So with that, we're going to draw this lecture to a close. The next meeting is on the 21st of July, where we'll be joined by Dr. Steve McFeely from WHO, giving more of a global view on the impact of the pandemic. So if you're around then please do come and join us. And also this session today will be up online too. We're recording it, so feel free to share it with friends and colleagues who are interested in this space. So very pleased to have you with us, Meng. Thank you for everybody for joining and staying the course, and thank you, Fergus, as well too.